Welcome to Spiritual Care Made Easy, a learning module for nursing students. My name is Carrie Dameron. I'm an associate professor of nursing for Ohlone College in Newark, California. I've set up this module for students to learn more about spiritual care and Ohlone College nursing program alumni. So I'm excited that you've decided to work through this module as a video, and I'm excited to get started. You may have already cared for a patient in clinical that you wondered about their spiritual health. They were facing a difficult diagnosis and are made statements about God or why me or some other existential statements. Maybe you've noticed religious symbols in the room and wanted to support their current spiritual health, as well as using this time in their lives to grow spiritually or find meaning through their illness and experience. All of this is spiritual care and is an integral part of nursing care. In the Ohlone Nursing Program, you are given some foundational parts of assessment of spirituality, and there are objectives scattered throughout the curriculum as the spiritual concerns be part of a patient experience. As an example, is with a cancer in the med-surg adult care. There was pediatric stuff in pediatrics and family facing a terminal illness. There may have been some spiritual stuff about pregnant women who may experience a fetal demise and others. Thus, you were given specific content that it applied to specific patient scenarios in a basic fundamental section. What is not available is a clinical module for when you have a patient in clinical and would like to write a spiritual care plan, which is what this is about. Yay! This module is designed to assist you in creating a spiritual plan for your patient, so I welcome you to this. To get started, I would definitely encourage you to listen to the chapter audio summary or read the Spirituality and Health in your fundamental textbooks. That's in chapter 29, and that will kind of help get your brain thinking about spirituality. So what are the goals of this module? First of all, you want to complete the module. There's going to be some case studies inside the module. You want to then, once you've completed it, you want to provide spiritual care and create a care plan on a real patient. That's really the best part. Then what I'm hoping you will do is upload it into the exemplary spiritual care section on the website. You want to remember HIPAA. Don't care who it is, we just want you to share your care plan. And then we'd like to hear you talk about your care plan or your experience for doing that. So I'm excited to see that. And then and this will support your colleagues and your peers in providing spiritual care. You've probably already seen the ones that I've uploaded from previous students. So please, you can take a look at those. So let's look at the objectives that we have planned for this module. First of all, we want to differentiate between religion and spirituality. Many times students and nurses are concerned about providing spiritual care or even asking about a patient's spiritual concerns because they're afraid of offending or being unaware of religious traditions and practices. So we will discuss the difference and help you to assist patients in meeting their spiritual needs. We will also help you write a nursing care plan using a case study. My goal is you'll be able to work through a simple spiritual care plan and then do one on your own patient in clinical. Of course, spiritual care planning includes using the entire nursing process with assessment, nursing diagnosis, interventions, and then evaluations. So we'll work through each one of those sections as we go. So let's look at the difference between spirituality and religion. Religion is a system and practices that people use to express their spirituality and is not required for spirituality. This is very important to remember, for you can't assume all people of a specific religion practice the same way, or patients who don't express a religion that they are not spiritual. The same religion may have the same basic idea, but is expressed differently. And you can look at your own spirituality or your own, if you do have a religion, how each one kind of practices in that religion differently. You may have things that are complete, that are very fundamental for that religion, but you may have people that do, different ways of expressing that. On the other hand, every person has a spiritual component. Even people who say, I don't believe in spirituality or practice spirituality, have a part of their being that is unexplainable and includes an interconnectedness to others, etc. Thus, they just they just they just may not label it as spiritual. So, religion versus spiritual care. Nurses provide spiritual care, not necessarily religious practices. The most important thing to keep in mind when trying to figure out religion or spirituality is to remember nurses provide spiritual care. Nurses can listen, guide, refer, and even provide interventions for all patients. There are other nursing interventions that may be religious or patient-specific that the nurse is competent in implementing. Also remember, not all people of the same religion practice for the same spiritual interventions. Even if two people of the same faith in the same practices, the practices may have different significance for each person. Some patients may need music, spiritual or religious readings, while others may want more silence and prayer. All people have the same basic spiritual needs that nurses can provide. And like other nursing skills, nurses can gain confidence and become more skilled at certain interventions than other nurses. We'll talk about some of those interventions later on in this module. So all people, need hope, security, love, and significance. So, those are basic things that we can try to assist our patients in finding. A broad definition of culture is various ways of living and thinking that are built into a person's life. When we think about spirituality, we remember that spirituality can be determined by culture and life experiences. We can see this within our own culture or religious groups. For example, cancer clients who have faith in a positive outlook on life might pursue more knowledge about their disease and continue to pursue daily activities rather than resign themselves to the disease's symptoms. Hall, in 1998, studied clients diagnosed with HIV and found that after suffering, spirituality frames individuals' lives. Individuals become open to discovering their unique spiritual meaning after a crisis that threatens health. Their faith becomes strengthened, and they are better able to go on with life and engage in activities that fit the new definition of themselves. And this research study was found in your fundamental books by Perry. So what about spirituality and health and well-being? It's defined as a sense of harmonious interconnectedness between self, others, and nature, and an ultimate other that exists throughout and beyond time and space. There are two important characteristics of spirituality about which most authors agree. First of all, it's a unifying theme in people's lives, and it is also a state of being. So when we look at how spiritual health is, it's horizontal and vertical. So horizontal, we think going up and down to God, life force, absolute, or whatever people want to identify it as. It's within ourselves, it's a state of being, and then it does include other people, meaning relationships with families, friends, forgiveness, and then also being part of a community as well. We are holistic beings. I love the little light bulb idea. I think it's a great way to show that without a strong electricity or spiritual health, then our physical and psychological or mental health can be affected. So kind of a little bit explaining the glass, the aluminum, the outside of the light bulb. The tangible materials represent our physical dimension. The light and warmth the bulb elicits is our psychological dimension, and then the electrical current that energizes and ultimately provides meaning and purpose is a spiritual dimension. I found this in Stolwood and Stoll. I found it by Stolwood and Stoll in Taylor 2002. And I think it's a great way to try to really explain to people about spirituality who have never, kind of sat down and thought about it before. So how does that look for holistic nursing caring? Well, first of all, overall holistic nursing caring does include some physical interventions. It's really about it's about how we are with our patients as well. Even though we're going to come up with specific separate nursing diagnoses and outcomes and interventions, much of what nursing is and what we do can be spiritually minded. Just the way that we can give physical interventions, the way we care for patients, do procedures, support them. Psychological interventions, therapeutic communication, understanding, listening, and then, of course, psychological or spiritual interventions with presence and empathy. So spiritual caring in the nursing process, remember, just like with planning any nursing care, we begin with assessment and then proceed through the nursing process. The difference for spiritual care is the process is informal and begins with building a rapport with our patients. I do have a link on the website under resources at the Ohlone Spiritual Care website on spiritual assessment made easy. This was an article I wrote years ago, quite a few years ago and stuff, and it kind of talks about the different, using the different systems of spiritual assessment. So you're more than welcome to pause this video and go look at that or go read it or refer to it at a later time. So when we start thinking about assessment, we can approach it from different ideas. First of all, we can look at patients' medical diagnoses or some of their current experiences and look that maybe they may be facing something difficult in their life, and this may give us a cue about their actual or potential spiritual concern. We don't want to assume that anyone with a chronic disease or terminal illness or experienced an acute trauma are going to struggle with spiritual thing. We just want to keep that in the back of our mind when we go to approach them. You know, we do want to always ask them, how are you doing? This must have been, this is difficult for you. Are you, hopeful? What's, kind of just some broad range questions that let us kind of give us an idea just related to their medical diagnoses. These are also times that people can begin to start asking spiritual-based questions. The other way that we do some assessment is listening for cues. Beginning to see, listening to what the patient may be saying. These are just a few examples that the patient might ask spiritual questions. So, one way that might happen is, let me give you a patient scenario. You're in the patient's room helping them with their bath and chatting about their medical diagnosis and treatments and that they've been receiving. They stop washing their face and ask you, why is this happening to me? Do you think I have bad karma? Or is God mad at me? These questions definitely will stop you in your steps. A few things to keep in mind when a patient asks questions like this are, first of all, they're not really questions for you to answer. They're usually ways patients and ourselves explore whether or not someone will talk to us about our concerns. Thus, we don't really want to answer right away. Most of the time, if you just listen, they'll continue on. If they don't, you can wait and then use good therapeutic communication techniques to say what makes you think you have bad karma. Do you feel like a lot of bad things have started to happen to you? Remember, the goal is for them just to keep talking about it. A good way I think for nursing students to become kind of more open to having conversation and listening to what patients are saying is, number one, to first of all, to take any of the above scenarios, a female undergoing mastectomy, a patient just diagnosed with type 1 diabetes, a child who has been diagnosed, a parent of a child who's been diagnosed with AML, a patient who survived an MI, all these. And then really, first of all, ask yourself, what would be some spiritual questions that you would ask if you were confronted with these experiences? Then write down all the type of spiritual questions that you would have. Write them out, just kind of brainstorm them out. And then come back and think about, if you were the nurse, how would you respond to those questions? Another thing, kind of something that can help you look at listening in difficult conversations is, I did upload into the website active listening difficult questions and stuff, and it's kind of a guide, and you're more than welcome to print that out and take it with you. I got that from the palliative care team at Kaiser, and stuff, and it kind of gets us thinking beyond what we naturally want to respond to, but maybe what the patient really wants to hear us say, or at least begin to think about it differently, which can be challenging. Some other clues that we might get is what's in the room. We can, what items might be at the patient's bedside to lead you to think that they practice a certain religion or use spiritual practices for comfort. Reflect back on some of the patient rooms you've been in. Have you seen pictures of gurus or spiritual leaders, miniature replicas, rosary beads, prayer cloths, books, scripture? Did you hear certain music playing? Aromatherapy, or some other type of thing that can give you an idea of how they are looking at spirituality. You can also do a more official assessment, you might say, or kind of a guided assessment. The other things are kind of when you're listening, you're anticipating medical diagnosis or looking for things, are also definitely cues or clues to give you an idea of what's going on. But then there's also a assessment tool that you can use, and this really can guide you in maybe some ways to ask certain questions. It's easy to remember, and they're an acronym. Like the acronym for PQRST for pain or FAST for a quick stroke assessment, FICA is just a spiritual assessment tool that we can use to kind of help us guide things. And, especially I think for people who are new to spiritual care or nursing students, it's simple, it's easy to remember, and it reminds us not only to ask, but to address things, to address certain parts of it. So first of all, you can change these words to what's comfortable for you to say. You could say, do you have spiritual beliefs that help you cope with stress? So, if you have someone who's, like we talked about, breast cancer, or a terminal diagnosis, or, a bad traumatic injury, you could say, do you have spiritual beliefs that can help you cope with this diagnosis? You verbalize that this has been a tough time for you. If they say no, I don't really have any spiritual beliefs, and then you can say, well, has there been anything else that's been supportive for you or gives your life meaning? So there's ways that you can change the wording of this. If they do say yes, I'm part of a certain group or whatever, you can say, are these beliefs important to you? Have they helped you in the past? Have they played roles in your beliefs regaining your health? Have you used this faith before? What parts of this faith has been important to you? Is there things that you do? Is it singing, worship? Is it being with other people? Are you part of a community? And then, of course, address or care. So this is just kind of a help to guide you in asking questions and kind of what we want to ask someone when we're thinking about spirituality and how we might be able to assess them. The next slide takes the FICA self-assessment. Part of what's important about spiritual care, and we'll kind of talk about that later on in this module, is your own self-assessment. So I've kind of tweaked this one a little bit for you as a nursing student and stuff, so that you could self-assess yourself. First of all, you can ask yourself, I have a spiritual belief that helps me cope with the stress of the nursing program, or with an illness or something else that's going on in your life? Is there something that gives your life meaning and purpose? Is this belief important to you? Does it influence how you make decisions? Are you part of a community? And if so, what should be my action plan? And I would say this is for you. What can you be doing? Are there spiritual practices I want to develop? Do I need to see somebody? What changes do I make? You guys do not take care of yourself because you don't have time. I'll say that as a nursing instructor. So this is just kind of a way that you can kind of self-assess and also learn to work with the tool. And then I give you the reference of where FICA comes from George Washington University and stuff. The person who created the tool is from there, so it's a great resource for you. Next, once we get assessment, of course, then we have to look at the nursing process for the diagnosis. And if you want to, you can definitely open up your Ackley and Ladwood book, because this comes straight from there. And these are the official nursing diagnoses that nursing uses when caring for a patient's spiritual needs. A reminder is to see that the two ways we can meet our patients' needs. If they're tied to a religion or belief system specifically, then our plan of care is directed in that manner. On the other hand, if their spirituality is not necessarily linked to a belief system, then we assist them in using their own identity and significance to meet their spiritual needs. So the first one is impaired religiosity, and that's really when the patient struggles to participate in their rituals or they struggle with their own belief system. An example, the patient states they have a good support system, they're active in their synagogue and pray regularly, but their recent diagnosis of lymphoma has really made her question her faith in Yahweh or God or whatever, Allah or whomever she's identifying connectedness with. Under the impaired religiosity is also the risk for impaired, like risk for used in infection and other nursing diagnoses. It means we are concerned the patient may begin to have difficulty participating in their rituals or faith traditions. So we want to encourage people, if it's important to them, any of those actually, even if it's religion or spiritual, if it's part of their spiritual health, we want them to continue doing what they've been doing to the best that they can, just like any other important function. Spiritual distress is when a patient is experiencing difficulty in finding meaning and purpose in what is happening. They may not have looked at spiritual issues before or were concerned about questions like meaning of life, illness, etc. When you enter the room, the patient may be angry and yelling about her breakfast, or on the opposite scale, she's buried under her blankets and doesn't talk with you when you take her blood pressure. Now, this doesn't necessarily mean that it's all about spirituality, but, could be just an example. Also, did you also notice how other nursing diagnoses can accompany spiritual distress? So people can be angry, and we don't understand why they're angry, but then later on we find out it's related to their spirituality. Or sorrow, or grief, or hopelessness, or loneliness, or something like that. So they could have more than one nursing diagnosis going on. Another one is readiness for enhanced, and that's readiness for enhanced spiritual well-being or readiness for enhanced religiosity. And I say it's like where we'd like all patients to be at, and that's because we really want patients to find meaning and purpose through their illnesses and suffering. When I worked in hospice, I would see beautiful examples of terminal patients writing stories, creating memory books, etc., to leave a legacy or memories for their loved ones. If their spirituality involves a faith tradition, we may talk with them about their experiences is increasing their faith, growing them spiritually, or finding a deeper purpose in their traditions. We assist with this by giving them space to complete them or meet their goals and purpose. Let's take our own same lymphoma patient and say she told you that her granddaughter is graduating from college next week and she wants to go. I would immediately begin working with her physician, social worker, chaplain, anyone and everyone of how we could get the patient to the graduation. Or maybe I would say it could be a graduation, it could be a baptism, it could be seeing her a bar mitzvah, whatever would be important to her, and then we'd work on trying to get her there and work with that. Imagine how we would feed her spirit through helping her see this wondrous event more significant than any of the other nursing adventures we could do. So, this would probably just make her day and really meet her spiritual need. So working with goals and outcomes, unlike other nursing diagnoses in the biophysical mode, where we want to see a kind of a resolution, in spiritual care, like other psychosocial outcomes, verbalization is always a great goal. So if they can verbalize, express, discuss, participate, choose, maybe find or whatever, then we can expect then that means it's success, where we've actually met our outcome. We can't expect someone to all of a sudden feel less spiritually distressed. Instead, we want them to discuss their concerns and/or spiritual needs. Or if the patient agrees that finding time to pray in the hospital is important, then a goal could be the patient will discover an intervention that decreases spiritual anxiety and foster hope. Personally, I feel like my goal is met if a patient will talk with me about what is going on in their life. then I know I've been caring and offered myself in a manner that they feel comfortable to discuss their spiritual concerns and worries with me, and I have met the outcome. So even if they're willing to talk with me and I can open them up to talk to someone else about it, or, even just to say, I feel better now that I chatted with you. That's a good goal, especially in spiritual care. Good goal anyway. So when we start planning interventions, we can think of the following 3 words. And this is from Verna B. Carson. She's one of my favorite spiritual care authors. She put in one of her chapters, Identifying and Meeting Spiritual Needs, she categorizes interventions in 3 ways. It's under presence, word, or action. And she does use the word ministry, not trying to tie it to a religiosity or a religious statement, but she states that using our gifts, talents, time, and energy in the service to others. So when we think of that word, we think of serving others. And so when we decide to embark with our patients and their suffering, we should see it as serving them or guiding them. Secondly, I love the simplicity of our interventions. They're easy to remember. For when you're standing there listening to a patient talk about their fear of dying, their hopelessness of the diagnosis, or their inability to meditate or pray, you can simply think, I can do the following. My presence and my word and my action. So it kind of helps you get organized when you may be anxious about what to do. So the first one, of course, is presence. Definition of presence is communicates personal spiritual strength and a willingness to care, listen, and be available to the patient. I took the presence as simply being with a patient, fully present, fully focused, not multitasking with IV lines. Now, I sometimes it may start that way, to where you're going in the room and you're doing something else, and then a patient may start talking to you or asking about things. But it means that we stop from what we're doing and we pay attention to them. So let's take this case example. So you're washing an elderly man's feet, and he's talking about being transferred to a nursing home. He states, I feel like my life is already over and I should just hurry up and die. You continue to wash his feet and continue the conversation. So you may say, what is happening in your life that you would like to be in a hurry to die? And he says, I'm just being put away in a nursing home. My wife is gone, my children never visit, and I feel alone and worthless. And you can respond by saying, this sounds like a difficult time for you. And he says, yes, it is. As he begins to share the events that have led up to this time, you finish washing his feet, find a chair to sit, and then focusing on him and listen to him sharing his feelings and concerns. So the point is with presence is you're going to continue doing what you're doing if possible. Finish your task and listen to him. And then what you do is you just take the time to sit back and continue to let the conversation go and let him share about what's going on with him. Presence is making time to be at the patient. Now, if the above scenario would happen when you're busy or you're interrupted with something important, you can say, I need to take that phone call. I will come right back so we can finish talking. Just be sure you come back. Notice how the above conversation included all aspects of pause. So pause and be present is something that I got from the Kaiser Hayward Spiritual Care Department when I was teaching students over there. And it really is about being purposeful in what you're doing. You're going to take the time and listen, be purposefully listening and present with them. Being authentic, just really sharing with them and authentic about what they're saying and caring, understanding, empathize with what the person is saying. Sacred space means you stop, you recognize, you get a chair, you sit down, you make room, you make time. An environment may be, like I said, maybe out of chair, but you may close the curtain or shut the door or anything else that may cause to interrupt the environment and get sidetracked would be part of what the environment is. Let's continue on with presence. Right here you'll see I talk about listening. The easiest yet the most difficult one intervention is listening. When students ask me how do I respond, most of the time I say just listen. Most of the time patients just want to verbalize and are not looking for you to solve their problems, like we talked about earlier with active listening in difficult conversations. This would also be a good time to mention caring presence. If you want to provide spiritual care, then it starts when you walk in the room. If you're rushed and not patient, stressed, frazzled, then your patient picks up on the fact that you don't have time. Also, a caring presence is also your attitude and actions all the time, not just when you are talking. An example is during your assessment. Are you calm, answering questions, dialoguing with your patient, or are you task oriented and not really listening to what your patient is saying? Um, and I will say that there are times when we are really busy, and that's okay. We do need to get things done, and that's acceptable. I think as students get more comfortable in their task and their skills and what they're learning, then maybe they can kind of be caring and sensitive and doing the task. That's all unique, different for each student. Because I do have some students that are kind of have a caring personality about them anyway, and it just kind of is part of who they are, and so it comes more naturally. And they can kind of do them both. And the point is that really to be present and to work on presence, we begin to think about it beyond just I'm providing spiritual care. It's more than just when you're walking with your spiritual plan of care and what to do. It begins in the beginning. It happens in the beginning of your interactions with your patient. You know, Providing a sacred space is another intervention. It's giving our patients space, time, and privacy to practice, explore, or communicate their spiritual needs. A great example, which happens frequently, is when I'm walking in a room to pass meds, and the volunteer sister of the Catholic Church or the father is praying for my patients. I immediately stop what I'm doing and wait for her to finish. Because I want to convey my support of the practice, I stand quietly with my head bent. When she or he is finished, then I thank them for coming to care for my patient. Um, I mean, Providing sacred space is not just about for yourself, but also for allowing others to provide that spiritual care for them. You may have a group of people up there visiting your patient from their church or synagogue or neighborhood, and they're praying or they're singing or they're chanting or whatever. Well, give them the time and the space to be able to do that. Shut the door, step out of the room, do what you need to do, and so your patient's spiritual needs can be met. Also, when those things are happening and you kind of walk in and or like I was mentioning about the sister or father praying with my patient, if you don't feel comfortable about what's going on, it's a different religion or you don't have time or whatever, it's okay to walk out. It's okay to back out quietly and close the door and come back later, and then, and just leave that space, that sacred space there. Um, Same thing can be if your patients pray. You need to, if they need special time, you can shut the door. If you can give them time, okay, your friends are coming at 2 o'clock, or your pastor's coming at 2 o'clock, or you normally pray with each meal. Okay, we're going to give you your meal, and then I'll step outside so that you can pray. Whatever happens to be their norm, it's all about sacred space, and those are some interventions that we can readily apply. So the next section of interventions that we're going to talk about is about word. As healthcare providers, we must choose our words carefully with the full awareness of the power of words to heal as well as to inflict harm. Really, best way to understand this is to take a moment to reflect back on a time when someone's statements were hurtful. Now think of a time when they were soothing or encouraging. So think about words that have been said to you, maybe during difficult times that you've had. If you were sick or you suffered a loss or stressed or whatever, what did someone say to you and how hurtful that was to you? At the same time, what was said to you that was encouraging and supportive? We can see the difference that our words make to one another. It's also We also want to bring in therapeutic communication too, and the fact that therapeutic communication that you learned in 301, your first nursing class, becomes invaluable to spiritual care. Just being able to restate, use open questions, and reflecting feelings back to patients can really encourage them to find their own way in spirituality and find their own way psychologically as well. So those are all great ways that words can help us. Also with Word, we look at the willingness to discuss spiritual religious issues. I kind of mentioned before that patients will say things like that just to see if you will talk with them. And not that they're trying to, but they may say, I'm really angry today or whatever, and they're just, they're just trying to see, are you willing to talk about that? Like how would you respond to a patient who says, I just want to die? If you go, well, why are you saying that? You get all frustrated and run out the room. Well, then they know you're not going to want to talk about those things. They won't bring it back up, just like you wouldn't. So, but if you say, what makes you think, what makes you say that, or why, what are some of the reasons that you're saying that? Help me understand what you're feeling, things like that. Then we can continue to help people and listen and stuff. So, we want to also support and encourage the patient's religious and spiritual views, whatever they're saying, whether we agree or disagree with them or whatever. It shouldn't be about whether or not we agree or disagree with them, but, that they can talk about things, their feelings and their opinions and their views and their faith without anything else. We also can do a referral to a chaplain or patient's own spiritual leaders. And then also scripture or other religious, we can, if we felt comfortable, we could read to the patient or definitely be able to get um, their readings or books or whatever is important for them. The next one is action. These are they're simple interventions, but they can also be so important to patients. We've talked about presence, we've talked about word, but then there's also things that we can do. And really, this is a broad spiritual intervention and applies to a myriad of ways that nurses and other clinicians demonstrate compassion and concern for patients and their family. I bring this up like pulling curtains, warm blankets, sitting with them. It shows us that many times just basic things that we can do can help, that can be spiritually minded. And one of the nice things about nursing students is you guys readily develop a rapport with your patients and have time to sit down with them. Many times nurses are challenged to find the time. We nurses hate to get involved in having a patient share their pain and struggle with an illness only for the phone to ring or another patient to put on a call light. It takes time and a commitment from the nurse to really want to meet a patient's spiritual needs. There are other interventions that are listed throughout the Lonely Nursing Program. We may have talked about hope and touch and presence, and there's some in your Med-Surg and your fundamental textbook. So make sure you look through those and see some specific interventions, and even your nursing diagnosis book by Ackley and Ladwig will give a long listing of interventions that we can do. That are not necessarily tied to a religion either. Other interventions that we can do are listed in complementary therapies, relaxation therapies. Chapter 35 in your fundamental textbook discusses many therapies, which are great spiritual care interventions that students can learn to do. You can even practice them on your friends and families. One thing nice about these relaxation therapies is that they are not specifically tied to religion or are overtly spiritual. Thus, a patient who does not practice spirituality will probably feel comfortable doing them. One of these is meditation, which is similar to prayer. Basic meditation is just a focusing on the mind and body internally. Some specific traditions use body movements, positions, etc. to assist in meditation. If this is something new to your patient, a simple way to learn to meditate is begin by thinking positive thoughts or an encouraging phrase like I am strong while focusing on their breathing. I included a link to the Wikipedia if you wanted to learn more about meditation. I also created a podcast of using breathwork and biofeedback entitled Breathe, Relax for anxious nursing students. So you're more than welcome to download that and listen to it. It's kind of corny. I created it. It's corny. But at least it just kind of gives you an idea of using simple words and breath and music as well to guide students and patients. And that's just for students kind of helped with that. Which also brings up music. Music can be very relaxing and spiritual. Of course, you need to discuss with your patient on what type of music they prefer. Music that may be spiritual to you may not be spiritual for your patient. So make sure that we want to make sure that we choose the right kind of music, and that we get them to choose the kind of music that would be encouraging, relaxing for them, and not something that we might choose. The next one is the act of prayer. I bring this up because sometimes this is a lot of what people think of spiritual care. They may go right away to prayer. Well, spiritual care is praying with your patient. Well, not necessarily. The quote here that I have is from your Fundamentals book that talks really a broad definition of prayer. Number one, it's just not specifically defined for specific religions or belief systems. Prayer for some patients can be non-religious and spiritually defined. And it's something many people participate in as well. There has also been research done on the effects of prayer. One study showed that patients who were prayed for after heart surgery had less complications and healed quicker than those who were not prayed for. At first, you may be concerned about praying with a patient, so like other nursing interventions, we want to begin with the FICA tool. So before we do any intervention, we would complete an assessment and see whether prayer is part of their faith or spirituality. If it is, what are examples of prayers that they have found encouraging? If not, discuss with them how prayer can be a source of support for many patients. Then we want to make a referral to a chaplain or a spiritual care coordinator in the hospital facility to help them find appropriate prayer. And I did link a link up there for BeliefNet of some different prayers that are related to faith and stuff that they might like. Remember, readings, poetry, passages, etc. can also be read as a way for people to find comfort and solace. Whether or not you pray with a patient is up to the patient. Our outcome or goal is to encourage them in being able to participate in their own spiritual activities. I think I would say prayer is something that many people want to do, but really it's about whether or not that's suitable for the patient, especially if whether or not you are involved. We can support them by giving them privacy. We can suggest prayers. We can find different resources for them. But I would say, especially in the beginning, I hesitate to have students even say that they will pray with patients, because I think that can be a very difficult concept for students. And so I think we want to be sensitive to that and say, no, maybe not. Unless, about the only time I would say you could, or I'd feel more comfortable saying you could, is if you shared the same faith belief system, and you're going, okay, this person's Christian, I'm a Christian, I can pray for that person. I'll ask them, hey, can I pray for you? Yay! Okay, we are happy now. We can pray. Otherwise I'd say no. It's more important instead that we just find them the resources and stuff and get them to pray. And to our first resource is not to say, can I pray with you? Some more interventions also is that we can do is journaling. Journaling is another great way for patients to meet their spiritual needs. They can freelance where they just write their feelings, ideas, or they can write a letter or a note and never send it. This is a great way for people to express their feelings of anger, guilt, etc. that they may be embarrassed or uncomfortable about. Remember, they are private and they can write them to whomever they please. I have encouraged patients to write letters to God and tell them exactly how angry they are at their diagnosis. Another one was with a patient who wished her mother could be there during a very difficult time. Her mother had passed away several years ago, and I encouraged her to write a letter to her, telling her how she missed her and needed her during this difficult time. Sometimes a piece of the journaling can be what to do with the letter. If it's anger or bitterness, people can tear it up or burn it, or in the case of the patient with her mother, she can keep it close, and it helped remind her that her mom was there helping her through this time. Another intervention is storytelling. It's just telling or reliving the incident. Patients can share when they found out about their diagnosis, when their family member passed away, or their difficult time receiving chemo. People are part of a storied environment, so no matter what someone's culture is, they may find comfort in just sharing their experience with you. This will help build rapport and open the door to other interventions. Also, we can do reading of spiritual books, literature, poetry that can be quite a source of spiritual strength and solace. We're familiar with books of religion, but there are also books of prayers, biographies, etc., that can encourage patients. And this is something, once again, you want to get what the patient wants. We don't want to necessarily suggest things, Um, especially if they're overt religious, like I think of chicken soup. Chicken soup is not, all those chicken soup books are definitely not necessarily, are spiritual books in a way, and they're not overtly religious. So you could do like a chicken soup for teenagers or whatever, something like that, or a book of poetry. And the best thing about this is we can make referrals to the chaplain and stuff, and they can help us find stuff that's more specific for what our patient may need. And that's exactly what collaborating with spiritual leaders is all about. First of all, hospital chaplains, spiritual care coordinators, whatever their title is, are greatest group of people. I think because of their vocational choice, they are calming presence for all of us, even nurses. Their job is to meet the spiritual needs of the patients. That is their goal, and they enjoy doing it. They're a resource for us and can definitely handle all kinds of spiritual needs. So when should we call them? When we need a book. I just talked about different readings or prayers or whatever. They're going to have them. They're going to have access to them, and they'll be able to find them. The need is great and beyond our time. So as nurses, we can call the spiritual care coordinator when we begin to discuss spiritual concerns with the patient and find out that they need more than we can provide for, or they need someone specifically. This is a good time to call the chaplain and let them know. An example of this that I encountered is when I was working in hospice, and there was a young mother who was dying of breast cancer and was being newly admitted to hospice. She had not told her younger daughters, who were old enough to understand, and I was concerned. I spoke to her briefly and understood her concerns and what she talked about, but knew she needed to talk with someone else about this. So I made a referral to our spiritual care coordinator, who was better trained to discuss the spiritual needs of young children than myself. So that was a great example. I knew that this was something she needed to really work on and stuff like that. And the spiritual care coordinator could help her with the spiritual needs of her daughters, which was something I was, being an adult med-surg geriatric person, I don't know spiritual needs of kids very well. Also, you can call a spiritual care coordinator when there's specific religious practices or persons is needing. If there's rituals that need to be done, books, blessings, prayers, whatever. If there's something specifically tied to religion as well, they're the ones who can find that or connect with somebody outside of the hospital. So they're a great group of people. Okay, so now is break time. So just take this time. It's been about, oh my gosh, feels like forever. It's been about 45 minutes. This is kind of a slide I put in there to say take a break because we're going to come back and work on some case studies. Hope you had a nice break and you're ready to get started. Got a drink, got something to eat, went to the bathroom. So you want to pull up the quick reference for spiritual care planning. You also can have your Ackley and Ladwood book open and a paper and pen or something to take notes on. Mr. G is a 54-year-old business executive with stage 4 lung cancer. He's admitted for palliative chemotherapy and radiation. He appears to be anxious and asks, what do you think happens to people when they die? So the first thing you want to do is write up questions that will help you explore spirituality with Mr. G. So going back to your FICA assessment tool, you're going to ask him about, well, first of all, let me back up and say this. You want to really just not, want to respond to that question. You want to listen to what he says, and maybe if you can say, well, what do you think happens? Those are one of those rhetorical questions where you can go back and put them on there and say, well, what do you think happens to people when they die? Is this something that you've thought about before? And respond to that. And then as the conversation goes, you could ask them about, is there a belief system that you've looked at in the past? Do you have a faith? Different questions. And really, I'm not going to go into specific answers for this because I think it's really good that you discover that this scenario could go any which way based on his answers. If he's not overtly religious, you could say he's a risk for spiritual distress or spiritually distressed, which could be as possible nursing diagnoses. Maybe he's never thought about this stuff before. He's never had um, never had really much religion or spirituality in his life at all, and he's just kind of anxious, like, I don't know. And you could say, well, you know, well, what have you thought about it before? Or was there something that, you know, or, what did you think about, like, if his parents were still around or his grandparents, what did you think about it with that? What was something that you were, when you were younger, thought about or were told? How do you feel about that? Um, once again, these are questions that people are just going to ask to get started about what you're thinking. At the same time, you can have the opposite view of being completely related, or not opposite, but the different view of related to a religion. Number three, you want to list some interventions that you would feel comfortable. So you just need to go through that list and think about interventions that you could do. I would say some ones that he would definitely is to talk with a spiritual care chaplain if he's really trying to figure out what happens after this. I'm going to die. I really want to know. And that's kind of his focus. Well, that's just something beyond that we can tell him. That's something that may take a little bit more time than someone who's uh, more experienced in chaplaincy, like your spiritual care coordinator, to really explore that with him and stuff. We can deal with his anxiety and stuff, and we can say, well, that's a really important question. I can imagine how difficult that is for you right now. Would you like for me to talk to, I can get the spiritual care coordinator or a chaplain to talk to you about that. You look really anxious right now. Is there something that could help you kind of get your thoughts together and be calmer about it? Or things like that. So you can just look at the whole list and see what you decide. An outcome would be that he's just as open to continue to talk about and explore it. Explore spiritual issues related to his diagnosis would be a great one. Or just to explore what he continually thinks about that he would talk to somebody else about it, a chaplain, or talk to this chaplain. Name one outcome that would communicate to you that Mr. G is struggling with spirituality. And that would be if he just kind of continues to be anxious about this. He doesn't want to talk. He's just angry about it. Well, I don't know. I don't want to talk to anyone. What difference does it make? And he continues to just digress. That may be really telling him that is struggling with spiritual issues, and that maybe say, well, I want to help you feel better about this, and some of these questions, I think those are valid questions that you have. If you want to talk to spiritual care coordinator, I'm happy to refer them to you. But if it's not something you're interested in, not interested at this time, then that's something we can talk about later. It's always here, so you can always tell any other nurse or anyone about that. So that might be a way that you see that he's, just doesn't want to talk about stuff. And that's okay. Remember, it's about what he wants and what's going to help him. And maybe today's not the day and stuff. And he's just kind of verbalizing without really wanting much assistance with it. And that's good too. Case study number 2 is AJ. She's an unmarried 22-year-old college student. She's miscarried a 5-month pregnancy. As she's prepared for a dilation and curettage, she angrily remarks, I know God is punishing me. Although her parents are Jewish, she's not participated in any religion for 5 years. So really what you want to find out with her, what are some questions? You want to see really how active her religion is in her life. It may or may not be, like I said, the answers are kind of like, is it or is it not? So using the FICA assessment tool, you could say, well, you say it says here that she's got that someplace, and if she had written that down, or she tells you in the conversation that her parents are Jewish, you may say, well, would that be something that would be supportive to you right now? Is there somebody you'd like to talk about? Or talk to about what is happening to you? Her possible nursing diagnoses would definitely be, or could be, related to religion or spirituality, depending on where she would go with this. Interventions, definitely, I can understand what you're feeling. Don't diminish her. Don't say, no, I don't think God is punishing you, because that's your personal opinion. And so you don't want to necessarily say that. You really just want to listen to what she's saying and say, well, why would God, help me understand how God would be punishing you for this, and just kind of dialoguing with her about that. and stuff, and just exploring it about it. Is there, you know, if she wouldn't be willing to talk to somebody who is Jewish, maybe she's kind of gotten away from that faith. You know, is there someone you'd feel comfortable talking with? Do you have a friend? Someone that you could share this with that might be a support to you before surgery? Um, really, so your name one outcome for your diagnosis and intervention would be too is that you want her to really feel better about it. She's about to have surgery, and it's a big thing, and there's a lot of emotions going along with a miscarriage and stuff, and so you want her to really just be able to talk about it and feel good, not feel good about it, but not be in such turmoil about it. And really, what you could do, the outcome that would communicate to you that AG is struggling with their spirituality would be that if she just continues to verbalize, you know, I can't do this, I'm not going to take care of myself, you know, that we're really where we see it interfere with her health, and proper follow-up would be a clue to something is really struggling with their spirituality. So you notice a possible care plan. You notice that I put individual based on assessment and express spiritual needs. One of the reasons I don't put the answers here is because I want you to kind of think about it and process it and get it and not create a cookie cutter plan. I give you ideas. I kind of made a bare bones a table or something to look at, that quick reference guide, so you have something that you can take with you to clinical and work your way through it. But the bottom line is I don't want to make a cookie cutter. We want to come along people on their journey and really assist them with that process without saying, okay, A plus B equals C, or something along those manners. You know, so I don't really sit down and say this was the answer to the previous case studies. The case studies are really things to help you get thinking about what you would do and how you would respond to those situations. Now is the time to really think about what about you or me. One of the important aspects of spiritual care is to see ourselves as healers. Nurses, like many other professionals in the helping profession, can get burnt out. We can experience compassion and fatigue, so we really have to take care of ourselves. And that goes back to that FICA self-assessment that I had you do. You need to be aware of your own spirituality. You need to take care of yourself, and really kind of be part of it. If how would you feel about these things happening to other people? How would you talk about it? What is your spirituality? In other words, in order for you to give spiritual care, you kind of have to know your own spirituality. Another thing to talk about when we're thinking about ourselves as a healer is to look at self-disclosure. Self-disclosure is a term used in spiritual care for sharing your private spiritual life with a patient. Most of the time is completely unacceptable, and I would say 99.9% of the time it is. As soon as we begin talking about ourselves, then the focus of our care is redirected to ourselves. Really, and there's been a lot of articles and research done about just the ethics of it. But as soon as I bring up myself and my own spirituality, then I muddy the waters of true spiritual care. And so the bottom line is don't. If you have questions or comments about that and want to dialogue with me further, additional resources, I'm more than happy to but to definitely give you some resources and some literature that I've been finding and stuff. So, you know, I definitely encourage that for you, for self-disclosure. Some healthy ways that we can do with ourselves is, like I said, self-awareness part of that is to recognize our own needs and responses and struggles. You know, we come alongside patients at very difficult times, and we are affected. We sometimes feel sad because of the things we see. We feel powerless because patients don't always get better, and we experience frustration when healthcare physicians, families, and colleagues, and even the patient stands in the way of optimum health and healing. This is especially true in spiritual care, where we decide to make a commitment and come alongside our patients in their personal journeys. Thus, we are affected. So these concepts are important for our own self-care. We need to have a self-awareness. We need to be doing activities, connecting, disconnecting, journeying, transforming. You know, we need to be verbal and nonverbal about some of that stuff. We need to recognize our own vulnerabilities. One great example I have of that is being affected by our care was a nursing student who was assigned to care for an elderly gentleman with Alzheimer's. Shortly after entering the room, she came out and was crying. She shared with me that her own grandfather had died of Alzheimer's, and she was reminded of her loss while caring for the patient. The nursing student needed to engage in some activities to work past her own loss and care for the patient. One thing I encouraged her to do was to reflect, on her grandfather and what nursing care he would have needed during this time. This is transforming the situation into one of empathy and caring. I later encouraged her, once she got home, to journal or explore the grief she was feeling. Notice how part of her self-awareness and care was both verbal and nonverbal for herself and the patient. It's so important that we care for ourselves, otherwise we're unable to provide competent, caring presence to our patients. And it will affect our ability to provide good spiritual care if we don't take care of ourselves. So putting it all together. So we want to, you can go and review the examples of the student spiritual care plans. I've put some up there from the past. You can choose one of the case studies that we did, and you can kind of send it to me if you want to work your way through it and kind of do that. And then you definitely want to complete a spiritual care plan. It says to email it to me. If you want to, you can email it to me, or you can upload it up onto the site. I think you've done a great job. I want to kind of to say yay. I hope we've increased your spiritual care competencies. Like I said, then next you can provide spiritual care and create a care plan. Provide spiritual care and create a care plan for your patient. And this one you definitely want to upload on the exemplary spiritual care. The other one, if you just wanted to do a case study and stuff, you could. But this one I want you to upload. If you do provide spiritual care for your patient in the clinical setting, then I want you to upload it into the exemplary spiritual care site. Remember HIPAA, even though it's private, we don't need names, hospitals, none of that stuff. It's just, just their initials. And then, of course, be sure to share your spiritual story. I think it's important for people to, your colleagues, to see how well you've done, and some of the experiences that. And this is my reference list, some other resources for you, and some references that I use for this presentation. I wish you well, and I look forward to seeing all your great care plans. Thank you, and have a good day.